Right now, today, millions of people over the age of 60 are taking a supplement they fully believe is protecting their heart and their brain. They read about it online. Their doctor mentioned it. They bought it at the pharmacy, probably a big bottle of it, and they take it every single morning without fail, proud of themselves for being so responsible about their health. That supplement is vitamin B12. And here's the part that nobody is talking about. For a huge number of those people, that B12 is not protecting them at all. It is quietly setting off a chain reaction inside their arteries that their doctor cannot see, that a standard blood test will completely miss, and that has no pain, no warning, no symptoms whatsoever, until the day something catastrophic happens. We are not talking about a rare or complicated situation. We are talking about two of the most commonly prescribed medications in the world. If you are over 60 and you take either one of them alongside your B12, your risk of a stroke goes up in a way that researchers at places like Harvard and the Cleveland Clinic have called one of the most underestimated dangers in older adults today. By the end of this video, you will know exactly which two medications cause this problem, why it happens inside your body in a way that is actually really fascinating once you understand it, what a simple blood test can tell you that your doctor has probably never ordered, and what you can do starting this week to protect yourself. So stay with me, because this one genuinely matters. Drop a comment below telling me where you are watching from, and while you are at it, hit subscribe and turn on notifications, because every single week we bring you health information, this specific and this important, that almost never makes it into a 15-minute doctor's appointment. The road to the pharmacy. Let us start at the beginning, because understanding how we got here makes the whole problem make sense. After the age of 60, the human body starts doing something sneaky with vitamin B12. It stops absorbing it as well as it used to. This is not a theory or a fringe idea. It is a well-documented biological shift that happens to almost everyone as they get older. The cells lining your stomach start to slow down their production of a specific protein. That protein is the thing your body uses to grab B12 out of food and pull it into your bloodstream. Less of that protein means less B12 gets through, even if you are eating all the right foods. The result? Fatigue, brain fog, weakness in the legs, sometimes a strange tingling in the fingers and toes that people often chalk up to just getting older. So a doctor runs a blood test, sees low B12, and the obvious answer is to supplement. Take a B12 tablet every day. The number goes up on the next blood test. Problem solved. Problem. Everyone goes home happy. And honestly, for millions of people, that is exactly how it works. B12 is important. A genuine B12 deficiency can damage your nervous system, accelerate memory loss, and yes, it also raises your cardiovascular risk in its own right. Supplementing is a reasonable thing to do. Here is the thing nobody tells you, though. The story does not end there. The form of B12 in that bottle, the dose, and especially what other medications you are already taking, those details matter enormously. Getting them wrong does not just mean the B12 does not help. It means the B12 actively makes things worse. And the two medications that turn your B12 from a friend into a foe are hiding in the medicine cabinets of tens of millions of people right now. One is for blood sugar, one is for heartburn, and together with B12, both of them trigger the same dangerous process, just through different doors. Here's where it gets really interesting. The molecule. Your doctor never checks. Before we get to the two medications, you need to understand a molecule called homocysteine. Bear with me here, because this is the key to everything, and it is actually not complicated at all once you hear the analogy. Your body is constantly running a kind of recycling operation. Every day, as your cells go about their business, they produce a waste product. That waste product is homocysteine. In small amounts, it is totally fine. Your body knows what to do with it. It uses B vitamins, specifically B12, B6, and folate, like a little cleanup crew that converts homocysteine into something harmless and flushes it out. Think of it like a factory with a conveyor belt. Stuff goes in, gets processed, and comes out clean on the other side. Vitamin B12 is one of the main workers on that conveyor belt. Without enough of it working properly, the belt slows down. homocysteine starts piling up. And a pile of homocysteine sitting in your bloodstream is one of the most damaging things that can happen to your arteries. Here is how to picture what it does. Your arteries are not rigid pipes. They are soft, flexible tubes, almost like a garden hose made of living tissue. They have a smooth inner lining that lets blood slide through easily, and they stretch and squeeze with every single heartbeat. That flexibility and smoothness is what keeps them healthy. Now imagine taking a handful of fine sandpaper and dragging it along the inside of that hose, every day for months or years. The surface gets rough, it gets inflamed, small cracks start to form, and those rough, inflamed patches become the perfect place for sticky cholesterol particles to grab on and build up into plaque. That is what elevated homocysteine does to your arteries. Research has shown that deficiency in B vitamins, including B12, can lead to elevated homocysteine levels, which have been linked to impaired endothelial function, increased oxidative stress, vascular inflammation, and activation of factors that promote clotting. The even more alarming part is not the plaque buildup itself, it is what happens to the plaque. Low B12 levels that lead to elevated homocysteine have been found to significantly raise the risk of cardiovascular disease and are strongly linked to stroke and heart disease in older patients. Specifically, plaque that forms in an environment full of homocysteine tends to be unstable. It does not stay stuck in one place like a boulder in a river. It breaks off in chunks that travel through the bloodstream until they reach a narrow passage, like the tiny arteries supplying blood to your brain. That is a stroke. Not because of a massive blockage that showed up on a scan, because of a small, unstable piece of plaque that nobody was watching, because nobody tested for the thing that made it unstable in the first place. Researchers have found that elevated homocysteine is present in a disproportionate number of people who have what doctors call unexplained strokes, strokes that happen without obvious cause. A 2024 systematic review and meta-analysis confirmed that homocysteine levels are a significant risk factor for ischemic stroke events. The cause was not mysterious. The right test was just never ordered. And here's the thing that should really make you pause. Homocysteine is almost never included in a standard blood panel. Your doctor checks your cholesterol, they check your blood sugar, they check your thyroid, they might even check your B12. But homocysteine requires a separate, specific test that has to be asked for directly. The Cleveland Clinic has described elevated homocysteine as a significant and massively underestimated risk factor for cardiovascular disease in adults over 60. Most people over 60 have never had their homocysteine measured once in their lives. So now you know what the danger is. Let us talk about the two medications that quietly fuel it, and why the combination with B12 is so much worse than either problem alone. The two medications. The first one is metformin. If you have type 2 diabetes, there is a very good chance you are already on it. It is the first medication doctors typically prescribe for type 2 diabetes, and for good reason. It is effective, it has been used for decades, and it helps keep blood sugar under control in a way that genuinely protects your health. But metformin has a side effect that most patients are never clearly told about. The diabetic medication, metformin, can reduce the natural absorption of vitamin B12 from the diet, especially in elderly people with diabetes. This is not a small or theoretical effect. Research involving over 2,500 participants aged 50 and over found that metformin use was associated with lower serum vitamin B12 concentrations in older adults. Here's how it works. Deep in your small intestine, there is a protein called intrinsic factor. Think of it as a very specific key that only works on one lock. The lock is B12. The intrinsic factor grabs onto B12 molecules in your gut and escorts them safely into your bloodstream. Without that escort, most of the B12 you swallow just gets carried out of your body before it can do any good. Metformin, over time, disrupts this escort service. It interferes with the calcium-dependent process that allows intrinsic factor to hand B12 off to the cells lining your gut. The longer you take metformin, the more disrupted this process becomes. After several years on the medication, a significant number of people develop what researchers call functional B12 deficiency, meaning their blood test might show a B12 number that looks acceptable, but the B12 is not actually getting where it needs to go to do its job. And what is its most important job? As far as your arteries are concerned, running that cleanup crew that keeps homocysteine from piling up. Low B12 levels that result from metformin use can lead to elevated homocysteine, which has been found to quadruple the risk of stroke in elderly patients, particularly due to its effects on atrial fibrillation. Now, here's where the B12 supplement makes things more complicated, not simpler. Your doctor sees low B12, prescribes a supplement, or tells you to buy one. You start taking it. Your blood test B12 number goes up, and everyone assumes everything is fine. But if the intrinsic factor pathway is compromised, that extra B12 is still not being processed and used the way it should be. The homocysteine cleanup is still broken, and the B12 is now circulating in your blood in a form that is not being efficiently converted, which means the homocysteine levels stay elevated even though your B12 looks good on paper. You feel fine. The blood test looks fine. But inside your arteries, the sandpaper effect is still running. This catches people off guard because they feel like they are doing everything right. They are managing their diabetes. They are taking their B12. They are following their doctor's advice. And they are, to be clear. But the specific interaction between long-term metformin use and B12 supplementation is something that the typical 15-minute appointment almost never has time to fully explore. Now, the second medication is one that even more people are taking. These are called proton pump inhibitors, and if that term sounds unfamiliar, you definitely know their brand names. Omeprazole, pantoprazole, lansoprazole. If you take a little pill in the morning for heartburn, acid reflux, or to protect your stomach lining, there is a very good chance it is one of these. Proton pump inhibitors, or PPIs, are genuinely useful medications. They reduce the acid your stomach produces, which brings real relief from painful heartburn and protects against damage from ulcers. And as people get older, acid-related stomach issues become more common, so these medications get prescribed more and more often. But stomach acid is not just an irritant. It actually plays a crucial role in releasing B12 from the food you eat. When you eat a piece of steak or an egg, the B12 in that food is tightly bound to proteins. Your stomach acid breaks those protein bonds and sets the B12 free so that intrinsic factor can pick it up and carry it into your bloodstream. Reduce the acid significantly, and that liberating step does not happen as well. The B12 stays locked to the protein and passes through your gut without being absorbed. Research reviewing the long-term effects of PPI use found significant changes in diagnostic markers of vitamin B12 status, including elevated homocysteine and methylmalonic acid levels, which are markers that define actual cellular B12 deficiency. Several long-term observational and population-based studies have shown an association between long-term use of PPIs and an increased risk of major cardiovascular events, vitamin B12 deficiency, and dementia. The FDA has issued safety warnings about the long-term effects of these medications precisely because the research keeps pointing in the same concerning direction. The particular issue with PPIs and B12 comes down to timing and dose. Your body can absorb a small amount of B12 through what is called passive absorption, meaning it does not need intrinsic factor at all. It just seeps through the gut wall in tiny amounts. So when someone on a PPI starts taking a large B12 supplement, some of it does get absorbed through this passive pathway. The problem is that passive absorption is unreliable. On some days, the levels going in are decent. On other days, due to shifts in gut chemistry and the acid rebound effect that PPIs are known to cause, the absorption is much worse. And an inconsistent supply of B12 means an inconsistent cleanup of homocysteine. Some days the system works, some days it does not. And arteries that are being scraped by homocysteine on an unpredictable, on-again, off-again basis are not in any better shape than arteries being scraped consistently. While tests to measure serum B12 levels are inexpensive and available, more sensitive tests that detect elevated homocysteine and other markers can identify early-stage B12 deficiency before the B12 level itself drops. And these are much less likely to miss a problem that a standard test would falsely show as normal. If you are on a PPI and supplementing with B12 at the same time, your standard blood test might look perfectly fine while the real problem plays out unseen. What you can actually do here is the most important thing to understand. None of this means you should stop your medications. Metformin and PPIs are prescribed for real reasons, and stopping them without your doctor's guidance could cause its own serious problems. And it does not mean you should stop B12 either. B12 is genuinely essential. A true deficiency will damage your nervous system, cloud your thinking, and yes, also raise your cardiovascular risk through a completely separate pathway. The goal is not less B12. The goal is smarter B12. The very first thing to do is ask your doctor for a homocysteine test, not just a B12 level, not just a B12 panel, a specific homocysteine test. The safe range is generally considered to be below 15 micromoles per liter. Many people walk around with levels of 20, 25, or even 30 without any symptoms, completely unaware that their arteries are under daily attack. Ask for this test specifically. If your doctor seems unsure about it, mention that the Cleveland Clinic includes it in their cardiovascular risk assessments for older adults, and that you would like it added to your next blood draw. That conversation alone could change everything. While you are at it, ask for holotranscobalamin, sometimes called active B12 or holo-TC. This is different from total serum B12. Total B12 measures everything in your blood, including forms that are bound to proteins and unavailable for use. Holotranscobalamin measures only the B12 that is actually available for your cells to use. It is possible to have a normal total B12 and a low active B12, which is exactly the situation that allows homocysteine to keep rising undetected. Next, look at the form of B12 you are taking. Turn the bottle over right now if you have one nearby. Most B12 supplements, the vast majority of what you will find at a regular pharmacy or big box store, contain a form called cyanocobalamin. It is the cheapest form to manufacture and it is everywhere. Your body can use it, but it has to run it through several conversion steps before it becomes the active form your cells actually need. The form called methylcobalamin is already much closer to the active state. It requires fewer conversion steps, which matters a great deal when some of those conversion steps are being disrupted by metformin or unreliable acid levels from a PPI. Research shows that methylcobalamin likely has a higher retention rate in the body compared to cyanocobalamin, meaning more of it stays available for use after absorption. For people whose processing pathways are compromised, that difference in retention can be meaningful. The dose is also worth reconsidering. Walk into any pharmacy and you will find B12 supplements in doses of 1,000, 2,500, even 5,000 micrograms. Bigger number feels like better protection, but the body can only absorb a limited amount of B12 at one time through the intrinsic factor pathway, regardless of how much you swallow. The rest either gets absorbed in tiny quantities through passive absorption, or it passes out of your body. What research supports for older adults, particularly those on metformin or PPIs, is a more targeted approach. A dose in the range of 250 to 500 micrograms of methylcobalamin, taken consistently combined with B6 and folate. These three B vitamins work together on the homocysteine cleanup process. B12 alone handles part of the job. B6 and folate handle other parts. Without all three, the system runs incomplete. Think of it like a three-person cleaning crew where you only hired one person. They can do some of the work, but the mess still builds up faster than one person can manage it alone. Clinical trials have found that daily combination therapy with folate, vitamin B6, and vitamin B12 lowered homocysteine levels significantly and reduced the risk of stroke in high-risk adults over 55 years old. The timing of when you take your B12 relative to your other medications also matters. If you are taking a PPI, your stomach acid is at its lowest point during the hours right after your dose. Taking B12 during that window means it hits a gut environment that is least able to release it from food-bound proteins. Taking it at a different time of day, away from your PPI dose, gives passive absorption a slightly better chance of working. If you are on metformin, ask your doctor specifically whether you should be monitoring your homocysteine level at least once a year. Research organizations have pushed for this to become standard practice for long-term metformin users, and it is a completely reasonable request. Healthcare professionals are increasingly aware that this is an underdiagnosed issue among elderly patients with diabetes on long-term metformin therapy, and that more sensitive testing is needed to catch functional B12 deficiency before it causes damage. There is also a practical conversation to have with your doctor about whether your PPI dose and duration are still necessary. Many people end up on these medications indefinitely after being prescribed them for a short-term issue. If your underlying problem has resolved, a lower dose or a different approach might be appropriate. That is not a decision to make on your own, but it is absolutely a question worth raising at your next appointment. Bring this topic up the way you would bring up any other specific health concern, not as an afterthought while your hand is on the door handle, but as the main reason you are there. Say clearly that you have learned about the interaction between your B12 supplement and your current medications, and that you want to talk through whether your current approach is optimal. Any doctor who is up to date on this research will take that seriously. Think about Beverly for a moment. She was 74 years old. She had been on a PPI for 14 years. She was supplementing with B12 because her doctor recommended it. She felt fine. She walked her dogs every single day. Her blood pressure was under control. She had absolutely no symptoms of anything being wrong. Her homocysteine level was 31. The safe level is below 15. She had more than double the amount associated with a seriously elevated stroke risk, and she had no idea because nobody had ever ordered that test. 3 months after her form of B12 was changed, B6 and folate were added, and the timing of her supplements was adjusted. Her homocysteine came down to 17. Still not perfect, but moving in the right direction with a speed that surprised even her doctor. She told the person working with her that she had not realized how tired she had been until she stopped being that tired. The body knows how to heal when it gets what it actually needs. The inflammation that homocysteine causes in arteries is not permanent if you catch it before a major event. The process is reversible. The damage stops accumulating when you remove the thing causing it. That is genuinely good news, and it is the reason why learning this today, even if you have been on these medications for years, still matters enormously. Your action plan. So here's what we covered today, pulled together into something you can actually use. If you are taking metformin for type 2 diabetes, you need to know that long-term use quietly compromises the way your body absorbs and uses B12. Supplementing does raise your blood levels, but the form and dose of that supplement affects whether it actually solves the problem or just masks it on paper while homocysteine keeps rising in the background. If you are taking omeprazole, pantoprazole, or any other acid-reducing medication long-term, the stomach acid that drug suppresses is the same acid your body needs to pull B12 out of food. The absorption becomes unreliable. The homocysteine cleanup runs unevenly, and the result inside your arteries is the same chronic scraping damage whether it happens every day or on an on-again, off-again schedule. The homocysteine test is the piece of information that tells you whether any of this is already happening in your body. It is a simple blood test, it is inexpensive, it is just rarely ordered. Ask for it by name. Ask for active B12, holotranscobalamin at the same time. Consider switching from cyanocobalamin to methylcobalamin. Consider bringing the dose down to a more targeted range and adding B6 and folate alongside it. Consider the timing of when you take your supplement relative to your medications. And most importantly, have the full conversation with your doctor. Not a quick mention, a real conversation with this information as the starting point. One more thing, if this video helped you understand something that you genuinely did not know before, please share it with someone over 60 who is taking any of these medications. One share might be the thing that sends someone to get a test they would never have asked for otherwise. That test might show a number that changes what happens to them next year. Hit like, subscribe, and turn on notifications so you see the next video the moment it goes live. Now tell me in the comments, are you currently taking metformin or a PPI alongside a B12 supplement? And has your doctor ever ordered a homocysteine test for you? I want to hear from you because the answers are going to tell us a lot about how common this situation really is. Take care of your heart. It is doing a remarkable job of taking care of you,